Sounds good.
Okay, welcome everyone to the session with Dr. Moldover. I'm sure a lot of you do know Dr. Moldover. He's an educator on his fields of expertise. He's a developmental neuropsychologist with over 15 years of experience in child and adolescent assessments, and he's board certified as a clinical neuropsychologist, and he's been the past president of the Massachusetts Neurological Society. He has a group practice in Wellesley, and they specialize in assessments and consultations for children and families with dealing with learning disabilities and developmental delays. So with no further ado, we will turn to Dr. Moldover for his presentation.
Okay, thank you, Ruth, and thank you all for being here today. We have let's see, it's 12:30 now, where I think we're scheduled to be here until 1:45, and I've been told that the link dies promptly at 1:45, so it will go dark right then. So what I'm going to do is I'm going to put up a PowerPoint presentation, and I'm going to talk to you all a little bit about evaluation in terms of how to understand neuropsychological and educational testing and how to use it as an effective tool in understanding and advocating for kids with and adolescents with special needs. And I believe the plan is that I'm going to take a couple of Q&A breaks as we're going along, and Ruth is going to route me questions you have at that point. So it's sort of a couple of times during the presentation, I'm going to stop for a breath and I'll say, okay, questions about what we've been talking about. I believe if you put it into the chat, Ruth will be able to route those to me. And this is a presentation that I have in various forms done before. However, I am today going to be sharing an additional section on assessment during COVID. So the last section of this is going to be all about how to understand and how to navigate evaluation during COVID, sort of with a focus on remote assessments, hybrid assessments, et cetera, and what's going on with that and how to understand that. So that will be, even if you heard me speak before, that should be new material. So yeah, this is me. As Ruth said, I'm a child and adolescent neuropsychologist. I do a lot of work with kids with learning disabilities, developmental disorders, psychiatric disorders, and I do a lot of collaboration with advocates in school districts. And that's my website on the slide. So this, when I talk about this topic, when I talk about doing evaluations, this is always where I begin. And the point of this slide and of this part of the discussion is this, that when we're doing an evaluation, we're trying to get to some sort of an answer. And if we don't ask the right question at the outset, then we are probably not going to be able to get the right answer. And so the first thing we want to be thinking about, whether you're a parent who's considering an evaluation, whether you're an advocate who's helping to guide a parent through the process, or whether you're me and you're having a preliminary meeting with somebody to talk about an eval, which is what I do. I meet with people, I meet with parents before we ever jump into the testing to decide if we're going to do it, if it's the right thing to do in the right time, and so forth. You have to define what is the question that you're asking. And you have to ask it very specifically and very clearly and very concretely of the person doing the eval. And in my mind, there are 4 basic questions that we ask in this business. And these kind of get more specific. You can obviously drill down on them, but it's 4 broad classes of question. And this is what they are. Question number 1, is there a problem? This is a classic question. Anybody who's met more than one child in their life knows that there's a lot of developmental variability. There's a lot of variability in child temperament and in child behavior. And classically, people will say, is this child just shy or just introverted, or might they have an anxiety problem? Is this child just a little bit of a late reader, or is it possible that they have dyslexia? Is this sort of a physical, energetic, hands-on type of a learner, or could this be ADHD? It's a question that oftentimes divides couples. Oftentimes, one parent or partner will have one opinion, and the other will have another opinion on this. So, this is oftentimes a source of friction within families, um, as well as between families and schools. Parents and teachers might be of different opinions about this. So the most fundamental question we can ask is, look, is what we're seeing just kind of normal variability in learning, in temperament, in personality, in behavior, or is this something that we want to tag as a clinical problem? And you don't want to make a mistake either way. I mean, you obviously don't want to miss clinical problems, especially because some of them have developmentally critical periods. Language, for example, it is much better to intervene with language deficits when a child is younger. And as they get older than about age 10, it gets to be a little bit tougher. Not impossible, but a little bit tougher. Um, on the other hand, we don't want to over pathologize. We don't want to take somebody who is somehow not fitting the mold of what we expect behaviorally or temperamentally or in their learning and tell them that there is something, quote, wrong, that there is a diagnosis, that there is a deficit, that there is a pathology. And so it's a difficult question. It's a common question. It's a divisive question. And it's one where we really want to be very thoughtful on both sides of the coin. Question number two, what is the problem? So for some of the kids who come into the office, we are past question one. There's no doubt that there is a problem. Some sort of a skill is so late to develop that it is clearly atypical. A behavior is so obviously problematic that there's really no contesting that it's a problem. Or the child themselves is experiencing and expressing a lot of difficulty. A child's very, very anxious, very unhappy. The child's suffering. And so it's very clear that we're in the territory of there being a problem. And once you venture into that territory, one thing that becomes really clear is that you can generate a ton of hypotheses for any given problem. So take, for example, a child in the middle elementary school years who's not yet reading, who's really not cracked the code with reading. Well, clearly that's a problem. Clearly that is behind age expectations. We're past question number one. Now we're into the territory of what's the problem? What is the problem? Is that dyslexia? Is it perhaps because of attention and executive functioning problems that are getting in the way of learning? Is it possible that it is a sort of the tip of the iceberg and part of a more global developmental delay? Is it a function of some sort of psychiatric problem that's obstructing the child's ability to make progress? That's sort of four hypotheses right off the cuff for that one problem. And so in those cases, the reason that we're doing the evaluation is to try to get the diagnosis. Those are diagnostic evaluations. We are trying to figure out which one of those hypotheses is correct. And we are doing the tests because we're looking for the fingerprint of that particular diagnosis. We're looking for the characteristic language profile of dyslexia. We're looking for the characteristic executive functioning problems for a child with ADHD. So those are diagnostic evaluations. The third category that we can think about would be, what do we do about the problem? And with these types of evaluations, we are sort of past the diagnostic phase. So with some children, the diagnosis is just never in doubt. For example, with children with Down syndrome, who I work with, where that genetic diagnosis is obviously clear from the start. Many children, especially in Eastern Massachusetts, are screened for autism at a very young age and may carry that autism diagnosis, and it may just be not a question, not up in the air what that is. So for these kids, when they come in, it's not so much about the diagnostics. It's not about what is the correct diagnosis here. The question is, what do we do? And I think this is oftentimes where advocates really get involved, because as in the prior question, you can come up with a lot, you can spitball a lot of different possibilities. Should a child be in an inclusionary or in a partial inclusion or in a sub-separate type of a placement? Is a child with autism a good candidate for ABA? What intensity of reading intervention should a child with dyslexia be receiving? Should parents of a child with ADHD be contemplating a medication consult? So these are all in the what do we do category. And on one hand, it's a positive that there are oftentimes many different options. We live in a time and a place where mental health resources and special education options are more plentiful and diverse than they have been in the past. On the other hand, I think it can create a real puzzle because there's obviously a limitation onto what any family can do in terms of time and money. And so figuring out what to do and then also advocating for what to do. If we decide that a sub-separate is necessary, if we decide that ABA is appropriate, that's obviously only part of the story. Part of the story is also making sure that that happens. So this is oftentimes where the advocacy gets involved. And then finally, question number 4, is the problem getting better? One of the things that I love most about my job is getting to follow kids over time. And I've been doing it for almost 20 years now. And so I get to have kids that I've followed from preschool who are now, getting out of college, and I'm seeing what they're doing. And it's wonderful. And in some of those kids, what I'm being asked, what the evaluation is about is, are things getting better? Are things changing? It can be deceptively hard to say. Parents and teachers who are with a kid day in and day out oftentimes don't see change if it's very incremental. It's kind of like the uncle who comes to visit once a year. And to him, it's obvious how much the kids have grown, even though for you, if you see it day to day, it's not quite as in your face. Um, Part of what also makes it challenging is that when we think about a problem getting better, we have to ask the question relative to what? And there are a couple of different ways of answering that question. Is the problem getting better relative to the child's own baseline? So the child's reading skills were at point X in June, and the following February, they're at point Y. And how much higher is Y than X? Are they progressing relative to their own baseline? Those types of ipsative comparisons are very important, but we can also ask, where is the child relative to norms? Where is the child relative to other children of the same age or the same grade or other children with the same diagnosis? Because of course, for many of these things, those are changing. If I personally have some sort of a cognitive problem, let's say I have a brain injury tomorrow, I'm trying to get back to my baseline after that. I'm trying to get back to where I was. I'm trying to get back to some sort of typical adult level. For kids, that comparison is not like this, it's like this, it's sloping up. And so even if that child who's in reading intervention is improving relative to their own baseline going from point X to point Y, you also have to ask, what has been the typical progress in their peer group during that time? Just because they've made progress doesn't mean that they've closed the gap with peers. It may be that they've kept pace, but they haven't narrowed that distance. It could be that they've fallen even further behind because even while they've progressed, other kids have progressed at a faster rate. And so this fourth question, is the problem getting better? It can be a tough one to answer, and we're oftentimes using our tests and the very precise numbers that they can give us as a way to answer that complicated question. How quickly are they progressing? What is their progress relative to personal baseline? What is their progress relative to peer group? And then once you have that data, that can then guide decision making. Most importantly, should we keep on keeping on as we are, or do we need to increase the intensity of the intervention? So that is sort of that slide. I know I've said a mouthful about it, but I just think it's a really important framework to put out anytime we're talking about evaluations. And I just think it's for anybody who's thinking about an eval, whether it's for their own child or for a child that they're helping, it's kind of the first conversation to have. Okay. I'm going to talk a little bit about testing. I'm not. This could sort of be a thing in and of itself, and I'm obviously keeping one eye on the time, so I'm going to go fairly quickly through this. But I'm just going to talk a little bit about the actual nuts and bolts of testing. Probably the most widely known and also controversial aspect of the test battery is the IQ test. Um, uh, so much that could be said about this, but I'll try to keep it brief. What it is, what it isn't. IQ tests, as originally developed over 100 years ago, were really intended to identify kids who needed additional help in school. And the basic insight that guided that development, which was originally in France, um, was that once a child falls behind, once it becomes obvious to everybody that that child is behind, it can be pretty hard to dig out of that hole. Partly because of what I just said, that you're trying to catch up with peers who are themselves moving forward, and also partly because you oftentimes have an overlay of emotional stuff, of anxiety and embarrassment and shame that the child is now contending with. It's an observation that I think we're all familiar with today. And the intent was to be able to identify kids who were going to be at risk before they fell behind. And so the concept was, well, if we look at a bunch of 6-year-olds or 5 or 6-year-olds or something like that, probably, a lot of them aren't reading yet. A lot of, they're not doing math yet. I mean, who knows? Who can predict who's going to be having a hard time down the road? Well, one way to predict it is to look at the skills that are involved in learning to read and in learning math and see who might have vulnerabilities in those areas, those foundational skills. What are those? Vocabulary, um, pattern recognition and pattern completion, short-term memory capacity, the nuts and the bolts that are involved in learning. And that if kids could be identified who have vulnerabilities in those areas early on, they could get remediation ahead of time rather than before they fall behind and not suffer those consequences. So in many ways, it was intended as kind of a progressive and effort. It has unfortunately many times been misused over centuries since it was developed. Uh, Good book if anybody's interested in that stuff, called The Mismeasure of Man, which is by Stephen Jay Gould, which sort of documents that history and how IQ tests have been used in terrible ways, or in discriminatory ways over the course of history. Um, Today, the main value of these tests is that modern IQ tests, which are quite different from the ones that were originally developed, do give us a window into the way that a child learns and a child's potential learning vulnerabilities. It gives us a window into some of the contrasts within a child's profile, verbal versus visual processing, uh, the conceptual nature of their thinking versus the speed of their thinking, etc. So I do consider IQ testing to be valuable in many, although not all, learning evaluations. But it's very important to understand that it is not, in terms of what isn't, it is not the be all and end all of who somebody is. It is not deterministic. It's not tapping into somebody's emotional resiliency, their emotional intelligence, their social skills, their creativity, many of the things that are probably more important in life than sheer IQ. And a very deterministic approach to IQ, saying, well, you get this score, you go to this whatever school or profession or whatever it is, I think can have very tragic consequences. So it is important to kind of appreciate their value, but not to overstate it. There's not only one IQ test, there are many different types of IQ tests put out by different companies. Probably the most famous ones and the most widely used ones in the public schools are the Wechsler scales. The WISC is the most common one for children aged 6 through 16 that you will see, the Wechsler Intelligence Scale for children. There's also the Stanford-Binet, the differential ability scales, the lighter. Probably just the key thing I want to say about these is that they do have somewhat different demands, especially around language. And so in theory, these tests are all measuring the construct of IQ, and you should be able to take any one of these tests and get roughly the same score. It's accounting for, sort of error. Um, in fact, though, if you're somebody or talking about somebody with special needs, you can get actually wider variability because, for example, the lighter scales are entirely nonverbal. They're entirely visual and hands-on. And that differs from something like the WISC, which has substantial language demands, even on the portions of the test that are more visual spatial. And so if you're talking about a child who has some language challenges, you can get widely divergent findings between those two tests. You can also, in terms of the last item there is the full scale IQ valid, you can also get very divergent findings within the measure. For example, somebody might do much better on portions of the WISC that are looking at language skills versus those that are visual spatial. In those cases, it may not be appropriate to merge all of those scores together into a full scale IQ, and the full scale IQ may be quite misleading. It may understate somebody's strengths and also gloss over their weaknesses. And so it's sort of another way in which the IQ can potentially lead us down the wrong road if it is misused. Um, Functional testing, these are other aspects of the battery. Is looking at different functional skills, academic skills, reading, writing skills, math skills, adaptive living skills, somebody's life skills and navigating the community, their domestic independence, etc. Vocational tests, looking at vocational preferences and abilities. The specific tests that are listed there, it's just intended to demonstrate, as with the IQ tests, that there's in any given category, there's a lot of different tests. They have different demands, and you can potentially get different findings using different tests based on those demands. We can talk about that more in Q&A if people like. So the testing I've talked about up until now is not necessarily neuropsychological testing. The IQ and academic and adaptive skills testing could be done as part of a school psychological battery done by a master's level school psychologist in any given public school, which is fine. What is the neuropsychological testing? The neuropsychological testing is intended to get under the hood and try to figure out exactly what is going on. So, you have a child who is, say we find his average or above average IQ and good math skills, but is a very disfluent reader with poor comprehension. Say that's coming from the testing we've just covered. Well, the question is why? As I said on the first slide, you can come up with a lot of hypotheses. Is it language? Is it attention? Is it executive functioning? Is it anxiety? This is where you're getting under the hood of the car to see, okay, what is it that's not quite working the right way? And that's what the neuropsychological testing is. It breaks down, these are sort of like the different parts. It's like, the fuel pump, the spark plugs, et cetera. This is what you're going to find under the hood. Somebody's language skills, their ability to process and to express language, to break language down into the small parts that are necessary for reading skills. Visual spatial skills, somebody's ability to process the nonverbal world around them, to organize it, to interpret it, including, crucially, social information, facial expressions, and body language. Much of what we take in socially is nonverbal, is visual spatial, is not said out loud. Fine motor skills, such as are involved for writing, learning and memory, attention and executive functioning, somebody's ability to remain focused on something that is not intrinsically interesting, which is oftentimes stressed in different parts of the school day. Executive functioning, somebody's ability to organize and plan and to integrate information, which is increasingly stressed as children go along in school, so that executive functioning problems oftentimes emerge in middle school or a little bit further along in high school. And social cognition, ability to understand other people, ability to understand what somebody else is thinking and feeling, ability to understand the impact that your behavior is having on somebody else. The basic thinking skills that are required for social and emotional competency. We also, try to touch on emotional and personality assessment. Um, Everything that I've talked about up until now is kind of hardwired types of stuff in terms of memory, attention, reading, sort of IQ, stuff like that. But we also want to think about some of the more subjective types of things. Is somebody introverted or are they extroverted? What is their level of anxiety and is it atypical for their age? Do we see signs of depression? We use both objective and what are called projective tests to do that. Many of you have heard of projective tests, things like the Rorschach ink blot test. Somebody might have a recommendation, might be told, get projectives for your kid, that type of thing. Objective measures are a little bit different. They tend to be more standardized and quantitative, things like questionnaires and so forth. Here's the key thing I'll say about these tests for this purpose. And again, we can do a deeper dive in Q&A if people want. You've got to be very careful with projective tests when you're talking about working with kids with special needs. And the reason is that if somebody is experiencing some sort of a challenge in terms of language or in terms of visual spatial skills, etc., it may lead to unusual responses to projectives that can then be misinterpreted. Very early in my career, I saw a kid who had been given the Rorschach by a psychologist, which is the ink blot test, where you look at the ink blots and you say what it looks like to you. And the parents had been given some very upsetting information about the child's psychiatric health. The child had looked at the ink blots and had seen a lot of bugs. Said that the little bits of ink looked like insects crawling all over the place. And the psychologist interpreted that as indicative of some major mental health problems. Well, in fact, what emerged was that that child really had an autism spectrum disorder. It was high functioning on the autism spectrum and had some very particular and fixed interests. And one of them was entomology, the study of insects. He was very interested in facts about insects and looking at insects on the internet and things like that. And so in his world, those ink blots looked like the thing he thought about all the time, which was totally natural. My point about that is that because that child sees the world differently, thinks differently, and has different interests, his responses to the Rorschach were quite different from that of children that psychologist was used to dealing with. And it led them down the wrong path diagnostically. So I tend to be very cautious about projectives with the kids that I work with. I rarely use them. And if they are going to be used for kids with special needs, they really need to be used by a psychologist who has expertise not only in projectives, but also in learning and developmental disorders. And there are not many people with that combined skill set around. All right, before I move on to any of these special topics, I've sort of just gone through about half an hour-ish of a ton of information about testing.
Yep.
Ruth, are there any questions you want to toss out?
There is a question. Yep. So Ginny asks, as an SESP, surrogate parent, and a school psychologist, how does the pandemic affect your testing decisions? Any remote or use of alternative sources as direct testing?
I am going to put that question off because I've got a whole section about it coming up in about 20 minutes. So it is a great question, and I've got a bunch of slides, and we're going to cover exactly that topic.
Great.
Great. So I will, Ginny, I'll be coming to that in just a few minutes. And Ruth, any other questions for me to tackle before I move on?
No.
Okay.
Let me see. There's one more that came up here. Let me see if there's, no, same question. We're good.
Great. So I know everybody wants to talk about COVID and testing during COVID. So let me just get through a few more slides, and then let's definitely jump into COVID. Okay. Topic I want to touch on here, just because it's so important and it oftentimes is underappreciated when people talk about assessments and neuropsychological testing. Testing for kids with mental health issues. So, between 1 in 4 and 1 in 5 kids have a diagnosable mental health disorder or addiction. Those will not necessarily all suffer from significant functional impairment. For example, I have a terrible snake phobia, completely diagnosable. Am I functionally impaired? Not really. I mean, I live outside of Boston. It's not something that comes up a lot. If I lived in the woods, it would probably be a much bigger problem for me. But 1 in 10 kids do suffer from something severe enough to cause significant functional impairment in their lives. That really undermines their ability to function. And the National Alliance for the Mentally Ill reports that only about 20% of those kids are identified and helped. In special education, as many of us know, emotional disorder is a disability category protected by IDEA. About 7% of students in special education are identified with emotional disorder. Oops, sorry, I moved on too quickly. Here's what I want to say about this. Many of these kids in this group, kids who are suffering from substantial emotional impairment, especially kids and adolescents with a history of psychological trauma, will experience significant learning difficulties as what I would call a downstream consequence. Oftentimes, these kids have a very difficult time with focus. They may be hypervigilant. They may be kids who are constantly scanning their environment, looking for any sort of threat, looking for any sort of danger. I think, for example, of a kid who came into my office where I do testing, and that room, the room where we do testing, deliberately has very little in it. Deliberately has, does not have a lot in there to be distracting. But there is a shelf or a windowsill near the table, set high up in the wall, with a little ledge, and on the ledge there's a little jar. Nobody ever notices it. I hadn't noticed it or thought about it in years. And the child came into the room and immediately said, "Please move that jar." Immediately, as soon as he came into the room. And I said, "Okay, but why?" And he said, "I'm afraid it might fall on me when I'm sitting there to do testing." So you can imagine how that child walks into a classroom, or sits through a lesson, or walks down the hall in school. And the amount of mental resource that is allocated to scanning and evaluating and defending against any type of potential threat, no matter how unlikely. And you can imagine the impact that has on that child's learning and memory, how few resources are left for them to be able to learn academically and to learn socially. So it's very important to understand that history in the kids that we work with. It's important that neuropsychologists be trauma informed, that neuropsychologists be able to incorporate those types of concerns into an evaluation, and integrate. On the last slide I showed, I was talking about social, emotional, and personality aspects of the assessment. Neuropsychologists have to be conversant with these tools, have to be able to assess, does this child have clinically significant anxiety? Does this child have post-traumatic anxiety? Is this child depressed? And so forth. Because even if the question that we're being asked is not specifically about a child's emotional state, even if the question that we're being asked is about learning disability or a developmental problem or something like that, if we don't understand this aspect of it, if we're not able to assess this aspect of it, we're never going to appreciate the whole situation and be able to give good recommendations. And you can imagine that for that child who walked into my office and was concerned about the jar, if his anxiety and his hypervigilance and his background with regard to psychological trauma was not incorporated into the evaluation, what's going to happen? I mean, you're probably just going to wind up with an ADHD diagnosis and a prescription for Ritalin or something like that, you're not really going to understand the full picture and the full scope, and the child's not going to get the help that he needs. So, okay, so I know that in many ways I've sort of sped through that aspect of this, and I know that I'm sort of trying to get to some of the COVID stuff because I know people are very interested. And I see the next slide is going to be about COVID and about remote testing and how we deal with evaluations at this moment in history. So I'm going to just hit pause again. Questions so far about the sort of the testing itself, about IQ testing, about the different types of academic testing and how you can wind up with different findings using 2 different reading tests, about neuropsychological versus school psychological testing and the difference between those things and the people who do those things. Just kind of the groundwork stuff. I want to make sure I'm addressing any concerns anybody has before we plunge into the brand new world of COVID and remote assessment.
Just Ginny's question.
The COVID
Right now.
question. The
That's
COVID
right.
question. Great. All right, so let's do that. So let us jump in there, and obviously we can go back to the other stuff later anytime anybody wants to. Okay.
I'm sorry. I just got a question.
Yeah.
Do you believe more testing is better, or do you think only 1 or 2 tests should be done in schools?
It's a great question. It's a great question. I think that, and it's an especially important question right now when schools are so overwhelmed by volume and are so challenged in their ability to meet it because of COVID. I personally am a proponent of targeted testing. I tend in my own practice to lean towards giving fewer rather than more tests. I think that if you're an experienced clinician and you take a good history, if you do the work that was on the first slide of this presentation and you really define the problem, then you should be able to go from there to a carefully selected battery of tests to answer that question and not force the child to sit through hours and hours of unnecessary tests. So, I certainly think that there are times to do a full extended battery, especially for a child who hasn't been evaluated before, where you have multiple hypotheses on the table for what might be going on. Then yes, I mean, by all means, do a comprehensive neuropsych or team or whatever. But certainly for the kids that we see who have been evaluated before, who, there are not major diagnostic questions, I feel like it should be possible oftentimes to hone in on exactly what is the question that we're asking and to answer it efficiently. And, I think that is good for kids who don't need to be pulled out for unnecessary testing. It's good for schools who are stretched very thin. In the private world, it's good for parents who are oftentimes paying for testing out of pocket, especially as health insurers have set fairly stringent guidelines around coverage for testing. Another thing we can talk about if people want to. So I don't think it's either or. I don't think there's just one answer, but I in answer to the question, I tend to be in favor of targeted batteries. When I teach clinicians how to do this, I try to teach them how to develop targeted batteries.
Okay, and now the next question is, how would you describe the difference between an educational model of NP, I assume neuropsychology, and a medical model? Did I get that right, Faith?
That sounds right. Okay. Yeah, the educational versus the versus the medical model. Well, I mean, there's a lot that could be said about that, but probably the main thing that I would say is in an educational model of neuropsychology, you're doing your work in such a way that it is meant to dovetail with the special education process. And what does that mean? That means that we are trying to arrive at diagnoses that we can translate into the language of IDEA, so that I might say this child has a language-based learning disability, but in the language of IDEA, this child has a specific learning disability as defined by this, whatever ability achievement discrepancy or whatever. So a lot of it is about the translation. A lot of it is about the translation between these two different worlds: the world of clinical practice and the world of education and special education. So that's one critical difference: is just being able to build that bridge to the schools. Another has to do with participation. I've worked in hospitals, and I love actually working in hospitals, but there are constraints on what you can do. A hospital clinician does not always have availability to attend a team meeting or to do a classroom observation. Whereas educational neuropsychologists are more likely to be working in the community and to devote a significant part of their time to actually being in schools, observing classes, going to meetings, if necessary, participating in BSEA proceedings, etc. And so some of it is also about the participation in the process. And then the third and last thing that I would say is that it's about the academic assessment. I think oftentimes more of a medical neuropsych will take a look at reading and math skills, but might not do as deep of a dive. Whereas typically when I do a battery for educational purposes, a very big chunk of the evaluation is devoted to academic achievement testing and drilling down on multiple aspects of reading, recognition, phonology, fluency, comprehension, multiple aspects of math. And so it's also about sort of how fine-grained you're getting around academic skills.
So Rebecca asks, how do you decide which tests to use?
So one thing that you're going to think about is what tests the kid has had in the past, as to if the child has had prior testing. If the child has had prior testing, you might choose to use some of those same tests in order to have an apples to apples comparison over time. It can be very helpful to say, on the Gray oral reading tests, this child had a reading quotient of 95 2 years ago. On that exact same test, they're now at 102 or something like that. So some of it is for comparison purposes. On the flip side, many of you have heard the rule of thumb that you don't want to give the same test twice within a given year. That's a very fuzzy rule of thumb. That is not a rule that's set in stone. That's not written down anywhere. But sort of as a basic guideline, people try to avoid giving the same test again and again within too short a period of time because of the practice effect, because the child gets used to explaining particular vocabulary words or has recently seen a given puzzle. And so sometimes we might actually use a different test if another test has been used too recently. If a child had a school evaluation last month and now I'm seeing them, I'm not going to give them the whisk all over again. So some of it is about the history. And then the final thing is about the specific characteristics of those tests. And this is where it really gets into the inside baseball stuff. And it can be very difficult for parents who don't have a background of their own in testing. But for example, just to take a basic example, some reading tests are timed and do not allow a child to look back at text to answer comprehension questions. Others are not timed. And when a child is asked a question, they can go back and study the text and try to pull out the answer. Now, there are many children, perhaps with dyslexia, who are bright kids, but are disfluent readers and have a very difficult time with first pass comprehension, because when they read the text the first time, they're devoting so much brain space to just reading it that they're not pulling the meaning out of it. You could imagine that kid having a very low comprehension score on the test that they read under time pressure, where they're not allowed to look back on text, but knocking it out of the park and maybe scoring above average on the other one, the one that's not timed, where they can look back. And so understanding those different sort of characteristics of those tests, if I am suspicious that this is a bright kid with dyslexia, which one am I going to choose to give him diagnostically? It's going to be the first one. It's going to be the time pressured one, because that's what's going to expose the vulnerability and give me the information. So in that sense, it's really kind of a professional question about understanding the diagnoses, how do people with dyslexia read, understanding the tests, what are sort of the nitty gritty of the GORD or one of these other tests. And people always ask me, how can I as a parent figure this out? And unfortunately, there's not really like a website that says, I mean, maybe I should build it. I don't know, although, yeah, I mean, it's not a website that says, here's the characteristics of this reading test, here's the reading characteristics of this math test. What I can say is that as a consumer of the information, it's very important to ask the question. So if you're sitting there in the team meeting, being told that your child is an average reader, but your sense, based on your experience, is that they're not, that they are struggling, ask about the tests. What reading test was given? What were the characteristics and parameters of that test? The task demands would be the way you might say it. Were they timed? Were they allowed to look back? And why was that test selected? And you can always question around the instrumentation to kind of get that insight.
Next question, what advice would you give on testing a child for dyslexia when the child has limited language ability?
Dyslexia, essentially is a language disorder. So, one of the misconceptions about dyslexia is that it's a visual disorder, that it involves left-right confusion or letters moving around on the page or something like that. And that's not true. Dyslexia is a language disorder. It is a difficulty making the jump from oral language to written language. So dyslexia is very, very common among kids with language disorders because it is basically an extension of that language disorder. Every child with a language disorder should be screened for dyslexia. You need to look at some very specific areas of language. You need to look at phonological awareness, the ability to discern and manipulate the sounds within words. You need to look at sound to symbol association, the ability to connect a visual image, such as a letter, with a sound. And you need to look at auditory working memory capacity, the ability to hold language online in order to be able to understand it. If the question is about, if the child has limited ability to read aloud, et cetera, that's going to sort of get into some of what I just talked about in terms of instrumentation. There are silent reading tests. So I was talking about the gray oral reading test in part of their last example. There's also a gray silent reading test. And so a child who from a motoric point of view has a difficult time with articulation and communication, we might elect to give an untimed silent reading test too. So it's not only is it possible to look at dyslexia for kids with language disorders, it's critical to do that. And it can be done, but sometimes it gets into this instrumentation issue that I'm talking about.
Okay, one more question. How often do you think kids with anxiety diagnosis have additional undiagnosed learning disabilities or other diagnoses?
I don't have a I mean, my off the cuff is, I think, fairly often. I don't have a percentage to give you. But I mean, two things I'll say about that. I think, first of all, anxiety itself can be quite disruptive academically. So, even if there is not an additional attention or learning disorder, anxiety itself, as I was saying in this slide, actually, in this social emotional slide, can itself be quite disruptive to learning. But secondly, I think, just a very, very common story that I see in my practice is that we have a child who is experiencing anxiety. And when you really sit down and talk to them and talk to their parents and dig below the surface, there's a lot of stress that is coming from schoolwork, oftentimes in particular from output demands in school, production, writing papers, doing projects and things like that. And it is fairly common in my experience that when you start looking, that is a child who has an attention issue, an executive functioning issue, a learning issue that has not previously been identified. A lot of kids with those issues will fly under the radar for quite some time. If a child is a kind of a bright kid with supportive parents and solid schools, I mean, you can go a very long way. One of the things I do is I consult with UMass Medical School, and I see their medical students and graduate nursing students who have learning and attention problems. Sometimes I'm the first one making the diagnosis. I mean, these are people who have made it through college and into medical school or into graduate nurse practitioner school, And now we're finally figuring out that they have ADD. Or do they have anxiety and stress? Oh yeah, I mean, because they've been sort of contending with this for so long. So the anxiety became first, and then when you dug underneath, there's a significant learning challenge.
Mm. Great. I think you can go on now. Thank you.
Okay, great, thanks. Those are
Thank you for
great.
those.
Yeah, great questions, everybody. Thank you. Okay, so the question of the hour. I'm not going to belabor this timeline because we have all just lived it, but I am going to touch on the last couple of points. So December 31st, first report of COVID in China. January 19th, the first US case in Washington. March 15th, Governor Baker closed the schools for 3 weeks, which was obviously became longer than 3 weeks. So obviously, as we all know, things have happened extremely quickly. May 13th, the Interorganizational Practice Committee, IOPC, which was a coalition of professional organizations involved in evaluation and assessment. The National Academy of Neuropsychology, the American Academy of Clinical Neuropsychology, a bunch of organizations, issued guidelines for telehealth, for doing assessment over telehealth. If you want to, you can go online and find those guidelines. They're posted online and Google IOPC. But the point about this is that at that juncture, by mid-May, that group had surveyed the scientific literature and determined that it was possible to do assessment using telehealth, that it was technically possible, that it was scientifically valid to do it by looking at the existing literature. And there is existing literature. I mean, for many of us, this is very new stuff. But I mean, one thing to appreciate is that Massachusetts, and especially the Boston area, probably has the highest concentration of child neuropsychologists of anywhere in the world. In many places, access is much more limited. For example, a lot of the research on remote assessment comes from Australia. Neuropsychologists are concentrated in Melbourne and Sydney, and there are huge sections of that continent where there isn't access. And so there are Australian researchers who have done a lot of work on it. Can they do neuropsych assessment from their office in Sydney to somebody 500 miles away out in a rural area? Similar work has been done in Texas, where they have similar distribution problems. So there is an existing literature on this. What happened, obviously, in the springtime was people in Boston got very interested in it very quickly. And the IOPC surveyed it and gave its recommendations and guidelines, indicating that it was a valid possibility. Now, different states had different reactions to that. So in some states, the Department of Education came out and said, no, we're not doing telehealth assessment. My understanding is that New Jersey, at least initially, had that. I don't know if they've changed that as things have gone on. Other states had a very different take. Maine, for example, did exactly the opposite. Said, okay, everybody is doing tele-assessment, and if you as a district are not set up to do it, we'll give you state funds to set up. So very different responses in different states about whether it was going to be permissible within the context of special education to be doing remote evaluation. In Massachusetts, we got our info just about a week after the IOPC. May 21st, Dr. Johnston, the State Director of Special Education at DESE, issued a technical assistance advisory, which you can see it on the screen, but states, when in the best interest of the student, the department recommends that schools and districts conduct assessments remotely. If assessments require in-person observation or face-to-face administration, assessments may need to be delayed until they're able to be done in person. The department recognizes that not all assessments may be conducted virtually, as a remote evaluation may invalidate results. So it's obviously a very sort of, it reads like a state technical assistance, but the point about it is that Dr. Johnston is saying that that it is, at least in some cases, valid to do remote assessment in Massachusetts special education, in contrast with some other states, but in keeping with the IOPC guidelines and other guidelines indicating that it is clinically and scientifically possible. So by mid to late May, the community had basically figured out that this could happen from a regulatory point of view and from a scientific point of view. And there was a pretty strong feeling that in many cases it should happen, because it is very difficult to manage in-person assessment during COVID. Like any in-person service, there are incidental contacts. People have to come into waiting rooms, pass each other in hallways. There are multi-user bathrooms, et cetera, et cetera. In addition, traditional psychological and educational testing requires extended one-to-one work. My batteries are typically, a full battery is usually about 6 hours long, 6 hours of face-to-face time. Many tests involve use of manipulatives, like the block design blocks from the WISC, where you're using plastic blocks to create designs. So there's contact issues. And look, I mean, the spaces allocated for testing are oftentimes not great. That's true in schools, that's true in hospitals, that's true in private clinics. Even in my office where I get to make the space decisions, it's pretty true. These are oftentimes spaces that don't have windows, that don't have great ventilation, that are fairly small, etc. So it is a very difficult activity to do with appropriate precautions and distancing. So I think now we're going to start to get into Jenny's question here, I think. So when we start to think about, okay, so there is a good reason to think about doing remote assessment. It is permitted by DESE to do it. It is deemed by IOPC valid. What are we talking about? So on the right side of the screen are the non-performance based tests, and this is pretty non-contentious. I mean, this is easy stuff. I mean, you can do a parent and teacher interview over Zoom, just like we're talking now. Student observations are tricky, but you can, try to observe in Zoom or via Zoom. Standardized questionnaires, I can have a parent fill out a ADHD checklist. I can ask a teacher to fill out a BASC as easily now as I could before. Many of them have been digitized to be done over email, so in some cases it's actually easier. So the non-performance based tests are pretty are pretty straightforward and can be done. What's more interesting and challenging and controversial are the performance-based tests on the left side of the screen. These are the tests that actually involve, obviously, a child's performance. It asks the child to do something, put a puzzle together, copy a picture, define some vocabulary words, memorize a word list, et cetera, et cetera, et cetera. These are all of the IQ tests that we've talked about, all of the educational tests that we've talked about, all of the neuropsychological tests that we've talked about, looking at learning and memory and attention and executive functioning. It's the tests used by speech and language pathologists. It's the test used by occupational therapists. It is really sort of the heart of the assessment battery. And, if you had asked me this time last year, if I thought an IQ test or a reading test could be given remotely over the computer, I would have been very skeptical. However, there are, as we've all learned, technological developments that actually do permit this to be done reasonably well. Obviously, the widespread use of online meeting platforms, such as the one we're currently using, Zoom. Digitization of test materials, this is important. Sometimes when people imagine doing remote testing, they imagine that like I'm sitting at my office, like I am now talking to you guys, and that I sort of have a test and I'm sort of like, holding it up to the camera and sort of saying, okay, look at this puzzle. Can you tell me sort of, which is the missing piece or something like that? They're doing something very kind of rudimentary or sort of kind of lame like that. One thing that's happened very quickly is that the companies that sell these tests have clearly seen what a problem this is for them and have moved very quickly to digitize the test materials. And so, for example, the visual stimuli for the whisk in the waist, the adult version of the whisk, have been digitized um, and can be screen shared, and are very high quality. And uh, and those companies, which are multi-gazillion dollar companies like Pearson, that design and produce and sell these tests, have done what I actually think is very impressive work around digitization to enable good quality online administration. And they've set up platforms. Pearson's is called Q Global. There are others, um, for doing online assessment. So the online assessment is actually fairly sophisticated, is much more advanced than just kind of holding things up to a camera or something like that. Pearson has also, and these companies have also been doing research on comparability of in-person versus remote assessments, so that we do have some data on that. And then also adjunctive devices like high definition document cameras, which would be just a camera that you can use that better than your sort of webcam to show materials to a child from home. So the technology around this is actually surprisingly good, in my opinion. Okay, so how is it done? I've done all of these over the course of COVID. So practice models at this point, full in person with precautions. I think this is what a lot of schools are doing. I have done them for some kids. It's sort of doing what we used to do, but doing it carefully. Precautions, PPE, air filtration, doorway screenings, etc. Some offices have retooled to put a plexiglass window between two adjacent rooms, so that a clinician and a kid can be in two separate rooms. In my office, I have a room with multiple remote control cameras and an intercom, so I can be in another room when needed to see the child both face on and look over their shoulder and to communicate with them verbally. So that's a video-enabled monitoring system. So yeah, those are the types of things that can be done to do it in person. You can go remote. You can, and full remote, non-performance based only. That would be a sort of a really quick and dirty evaluation where somebody's just going to interview you, email you a questionnaire, and call it done. Sometimes it's appropriate, especially for reevaluations, if somebody's up for their triennial and there's no real pressing questions about, everybody's fairly satisfied with what's going on. That may be appropriate, but it's obviously not a full evaluation. It's obviously only a fraction of the information you're going to get from a full eval. Full remote with performance and non-performance based, that's doing the whole thing over remote. It can be done. I've done it a couple of times. I've done it with people who can't or won't come into the office for any portion of the testing because of medical complications and vulnerabilities. Not all of the tests have been digitized, so sometimes you've got to be creative, use one test instead of another. It's challenging. This may be what we're all doing in January if rates continue to go up. So probably the take-home point here for everybody listening is it is doable. It is doable. And none of us on either side, the assessor side, the clinician side, or the parent guardian side, should be forcing in-person work that we don't feel comfortable with, because it is possible to do it remotely. If you have a health condition, your child has a health condition, if virus rates are getting really, really high, it can be done remotely. And probably what we've done for much of the late summer and the fall is more this last option, the hybrid. And I think this is probably the most common one in the private practice world right now. And this is doing a combo. What I often try to do is do some of the testing remotely and in a couple of short sessions, and then do a single in-person visit that's much shorter than what it would have been pre-COVID. My personal feeling is that people get Zoom haze after about an hour, and I appreciate that you're all sort of coming out just past that mark with me, so thank you for hanging in there. I usually will do a telehealth session. It's like an hour 15 with a kid. So I might do like 2 hour 15 sessions and then do a single in office session that's longer with obviously with masks on. Um, as I said earlier, a full battery for me would be 5 or 6 hours. Doing it this way, I can whittle the in-office time down to 2 or 3 hours. So we still have face to face, but we're only coming in once. It's fewer hours. It's risk mitigation. And so the hybrid, I think, is where, as of today, mid-November, a lot of us are. And but again, I mean, I've done all of them. I think we should be able to do all of them. Um, the last thing I'll say on this slide, and it may be anticipating a question some people have, is what about the kids who can't do tele? What about kids who, because of developmental communication issues or whatever, are just not going to be able to do the telehealth? Um, you've got those are kids who I will see full in person with precautions at this point. Again, come January, I may not be doing that. A child who can't wear a mask, I will get calls about kids who, for sensory reasons, won't or can't wear a mask. I'm actually not having those kids into the office at this point. We do have somebody in the office with an at-risk medical condition, and so we are not seeing those kids at this point. Although I have been able to do a full remote of a child who wasn't able to wear a mask, with the parents collaborating at home to assist in the process, and we were able to do a fairly good autism evaluation with parental assistance on the home side. So different practice models, different ways of doing it and putting it together. And probably the single most important take home. Sorry about that. The single most important take home I want to give people is that you do have options. There are these options, and just the thing I can't emphasize enough is nobody should feel like they need to put themselves or their child in unnecessary, unwanted, unacceptable risk in order to obtain assessment. This is, I think this may be the last slide actually. Trying to point this out to people. Uh, there has been, as I showed you earlier, Dr. Johnston's directive opened the door to doing remote assessment in Massachusetts special education. There is district by district variability in how special education directors and team leaders are greeting remote assessments or assessments that are done partially remotely. And it is sometimes with some pushback and some skepticism. And sometimes that's fair. We know that it's not right for every situation and for every kid. This is a document that I think would be helpful to parents and to advocates, though. Again, available online. I could send it to anybody who wants it, but it's just briefly, it's a joint statement that was put out by the Massachusetts Psychological Association and the Massachusetts Neuropsychological Society, which are the two main state organizations, put out jointly on June 8th. And what it said, it was not speaking to schools, to school psychologists. It was not trying to tell school psychologists what to do or what not to do. It's really for neuropsychologists, for people practicing independently in the community. And it acknowledged that remote assessment is not appropriate for all students. It went through a number of reasons why that might be the case, including socioeconomic disparities in terms of people's ability to access appropriate technology and space in their homes. However, it also talked about the drawbacks of not using remote assessment. And I think I'm sort of preaching to the choir, I think, if I go through those. But what it boils down to is you're going to wind up having parents and teachers who are stuck between a rock and a hard place, who can't assess eligibility, can't assess progress, without potentially doing something that they don't feel comfortable doing from a safety point of view. And that's a terrible situation to put people in, and it's a sort of an unacceptable dilemma. And so therefore the MPA and MNS recommended that those statements be used and gave some very specific recommendations about their used judiciously, and gave some very specific recommendations about the use of those remote assessments in special education, specifically recommending that an evaluation should not be turned away by a district simply because it uses remote, and that districts that are contracting for independent evaluations should not forbid the use of remote in those contracts. So that joint statement, again, a public statement by the two state organizations, and I think can be a useful advocacy tool if a family or an advocate is encountering some pushback around remote in the special education process. And that, I guess, is my last slide.
I have one question here.
Yeah.
Ginny is asking, could you please put the link for the international guidelines that you spoke about earlier? Said right now NASP is advising against it, but it's good to know that DESE allows.
Yeah, I've looked at the NASP. So NASP, for anybody who doesn't know, is National Association of School Psychologists. I had looked at NASP guidelines fairly recently, and my feeling was that they were sort of expressing some hesitancy and skepticism, but I didn't necessarily feel that they were directly advising against it. I don't know, Ginny, if you want to relay to me by Ruth if you have any sort of updated information about sort of a new advisory from those folks. Let me see. I think if I stop screen sharing with you guys, I may be able to give you some information in the chat. Yeah, IOPC is again the Interorganizational Practice Committee. Give me a second and I will just give you a URL to look at. It is IOPC online, https://IOTPC online. Let me see if I can put it in the chat.
Ginny says MSPA is advising against it, and they are following NASP.
NASP is, yeah. So the NASP is, again, the National Association of School Psychologists. I mean, I guess one thing, so I just put in the chat, I hope everybody can see it. I just put the IOPC link in the chat. Well, I guess one thing I would say, Jenny, is that, NASP, I mean, is a professional organization, but they don't actually have authority to tell districts and school psychologists what to do. Dr. Johnston, as I've said, at DESE, as I said in the prior slide, I mean, has recommended that it be done as appropriate. I have been doing trainings for school psychologists. I gave, together with my colleague, Dr. Bill Motz, I did a presentation for DESE about a month ago. We had about 500 school psychologists and special educators from across the state on that webinar. I've done some for individual districts for their special ed staff, training people or teaching people about using remote assessment. So it is certainly in Massachusetts what the NASP again is a professional organization. They can sort of issue their guidelines, just like IOPC. I mean, IOPC also can't tell anybody what to do. It's just sort of professional guidelines. But the authority, I guess, is sort of DESE, Department of Elementary and Secondary Education.
So we're going to get cut off in a few minutes here,
okay,
but
yeah.
I just want to thank you for the great information, for sharing your expertise. This is obviously a very, very important topic for those of us working in special education, be able to get those services for kids. And thank you to all who have participated today. We look forward to the next opportunity to be together.
Thanks, everybody. Good luck and stay healthy.
Thank you. You too.